The following podcast is part of a certified educational activity titled Intensifying Treatment for Type 2 Diabetes According to Current Guidelines, an office hours activity. Access the entire activity and complete the post-test at peerview.com/NRC 860. Downloadable slides and practice aids are also available.
Hello, welcome to Intensifying Treatment for Type 2 Diabetes According to Current Guidelines, an office hours activity. My name is Dr. Vinita Aroda from Brigham and Women's Hospital and Harvard Medical School. I'm so happy to be here with you today. Let's begin. Our goals for today. We want to augment your knowledge of the long-term consequences of therapeutic inertia, meaning the failure to intensify treatment in people with type 2 diabetes. And we hope to equip you with strategies to intensify treatment to help people with type 2 diabetes reach their glycemic and weight loss goals. Time is of the essence, so let's begin. We have no time to lose. Intensifying type 2 diabetes treatment to minimize complications. The neat thing about being part of educational activities is even now the educational activities are evidence-based. So what you see here is that today's webcast was designed to fill gaps exposed by other recent CME activities on type 2 diabetes and weight management. So in previous activities who answered correctly, they were able to recognize that timely intensification is linked to improved patient outcomes. They were able to cite evidence-based rationales that are aligned with the guidelines. They said that they needed suggestions to balance the real-world treatment challenges. Those who answered incorrectly in previous CME activities recommended less effective agents, focused on agents that with modest benefits, and didn't anticipate the patient willingness to select the newer or optimal agents. And in those who were unsure of their answers, there was hesitation to commit to more aggressive or more intensive treatments, and they preferred more time to meet goals, maybe additional lifestyle changes. This is all familiar to many of us, and there is uncertainty around newer agents as well as current goals. So let's address this. Consequences of clinical inertia, starting with the comorbidities and complications in persons with type 2 diabetes. What do we mean by clinical or therapeutic inertia? You've probably heard this term in many different contexts. What therapeutic inertia refers to is the delay or inaction to initiate or intensify therapy when glycemic treatment goals have not been met and are clearly indicated. So something should be done, but it's not being done. And this means that it could mean being slow to add or change the care plan if the patient's A1C is too high relative to their target. That care plan may include medications. It could include health checks, diabetes education, nutrition therapy, exercise, and emotional support. The American Diabetes Association advises clinicians to advance therapy if a patient doesn't get to goal within 3 to 6 months. And this has been part of the standards of care since the first standards of care was published a couple of decades ago. But what we've seen is that despite the availability of therapies as well as other approaches, studies show that it can often take more than a year to intensify treatment, and time is of the essence. To give you a snapshot of how important the time in treatment intensification is, here's a snapshot looking at the cardiovascular risks of a 1-year delay in treatment intensification in individuals who have an A1C of above 7% or less than 7%. And as you can see, there's a dysglycemic legacy that starts from the get-go, that starts from diagnosis. So here, both groups had a baseline A1C on average of 8.1%, but in those who intensified treatment and had a lower A1C compared to those who did not intensify treatment and had a higher A1C, there's a discrepancy in long-term cardiovascular risks. At 5.3 years, there's a higher risk of MI, stroke, heart failure, and composite cardiovascular events in those with an A1C of 7% or greater without treatment intensification. Now, what we've seen, again, consistent across all studies, is that early glycemic management matters. This is from the Diabetes and Aging study, and I call this the glucose pack years concept, where what you see is compared to within that first year of diagnosis, compared to maintaining an A1C of less than 6.5%, even a slightly higher A1C in the blue circle a 6.5 to less than 7% is associated with an increased risk of microvascular, macrovascular complications and mortality. And that risk increases as we get to higher magnitudes of A1C, above 7%, above 8%, and above 9%. Now let's increase the exposure time. What happens if you have increased exposure to higher glycemia over 2 years, 3 years, all the way up to 7 years? You can see an amplification of effects. So you see a cumulative risk based on glucose exposure. Hence, the time starts from the diagnosis. And what we've also seen from large epidemiologic studies is that early weight management matters. Here you see from large cohort studies that increased body weight in both middle-aged men and middle-aged women is associated with an increased lifetime risk of cardiovascular disease, morbidity, and mortality. And what we see is that the lifetime risk for total cardiovascular disease exceeded 30% for men and women in all BMI groups, that participants in higher BMI strata had higher lifetime risks for cardiovascular disease through the age of 95. However, all-cause mortality was higher for underweight individuals. So keep that in mind as you tailor it to the individual in front of you. Next, let's explore glycemic and non-glycemic effects of therapeutic options. So what a day and age we live in where, it used to be where all drugs were kind of created equally, but that's not the case in diabetes. And what we have now is comparative efficacy studies and network meta-analyses that really kind of give us a snapshot of the differential efficacy of the glucose-lowering regimens that are available. What you can see here, this is a meta-analysis published this year looking at some of the higher efficacy treatment approaches. This one is looking at tirzepatide, which is a GLP-1 and GIP dual agonist, as well as GLP-1 receptor agonist in combination with basal insulin, as well as GLP-1 receptor agonist in combination with SGLT2 inhibitors, as well as the high-potency GLP-1 receptor agonists. And you can see that we have a higher potency in terms of change in A1C and change in body weight with the tirzepatide or with the combination therapies. So we're definitely entering a new age of efficacy with the agents that are in existence. And compared to the olden days where we had higher risk of hypoglycemia, especially with treatments involving insulin, we are now able to nearly eliminate that risk in our patients with type 2 diabetes, dependent on the therapies that we choose. I love this heat map that we put together really to show you the differences of the different incretin-based therapies, the GLP-1 and the GIP, et cetera, based therapies in terms of their effects on A1C lowering, as well as body weight. And what you can see is that we are definitely entering into a generation of higher potency agents that are able to see greater A1C reductions. We have the highest potency with semaglutide 2 milligrams weekly or tirzepatide at 10 and 15 milligrams weekly in both A1C reductions as well as body weight reductions. Now, how do we translate that at the bedside? One of the conversational points that we often have with patients in terms of goal setting is the impact of weight loss on some of the medical comorbidities. What we're all used to and we've all been trained is that 0 to 5% and 5 to 10% of weight loss can improve blood sugar, it can improve blood pressure, it can improve lipids, it can improve menstrual cycles, for example, in PCOS. But what we're also starting to see with some of the outcome studies is that once you achieve 10 to 15% or over 15% weight loss, we are now seeing the ability to impact disease modification or disease course. So in goal setting, we can aim for what our target weight loss is, depending on what the goals are. What's also exciting in the field of metabolic therapeutics is that even the current incretin-based therapies are more effective than the traditional weight loss pharmacotherapies that we've seen. So here we have the mean weight change from baseline with tirzepatide, higher dose semaglutide, phentermine topiramate, liraglutide, naltrexone, bupropion, and orlistat. And you can see that we've definitely entered an amount of weight loss where we can modify disease course. So now let's switch gears to the American Diabetes Association Standards of Care, where I've been really privileged to be a part of the process. So in 2022, the ADA and EASD in combination issued this consensus on approach to glycemic management in type 2 diabetes. And I was privileged to be a part of that process, focusing on the therapeutic section, What we all agreed upon is that the goals of care start with the person at the center. Their goals are to prevent complications and to optimize quality of life. We also realize that there are many principles of care that we need to recognize in order to support the person at the center, including, for example, shared decision-making, paying attention to our language, making sure that there's structured education, support, that we're looking at the whole picture of not just medications, but also health behavior modification. In terms of medical approaches, these are the 4 cornerstones that we focused on. One is making sure that we support glycemic goals through our glycemic management and the medications that we choose. 2 is recognizing weight management as a co-primary to glucose management and addressing it through any number of evidence-based tools that we have. In addition, not to forget that type 2 diabetes does increase the risk of cardiovascular disease, and therefore it's important to pay attention to and focus on cardiovascular risk management. And lastly, we have entered the era of the cardiovascular outcomes trials where we do have 2 classes of medications that can support cardiorenal protection. In other words, reduce the risk of cardiovascular disease and kidney disease. So there are specific agents within the GLP-1 receptor agonist class and the SGLT2 inhibitor class that has evidence to do so. I want to break it down a little bit further. So if we look at the algorithms in the international consensus, there are different buckets. So different agents of medications for the different health priorities. For the goal of reducing ASCVD risk, we again know from the CVOTs that there are specific GLP-1 receptor agonists and SGLT2 inhibitors with proven cardiovascular disease benefit. They are listed here. In terms of reducing A1C, we were very deliberate in the language that we chose here. We will all recall that in previous iterations of guidelines, the foundational therapy was metformin, and add a second therapy, add a third therapy. Here we said, keep the eye on the goal. Choose approaches that provide the efficacy to achieve goals. This may be metformin, this may be combination therapy, this may be a choice from any of the tiered therapies from very high to intermediate efficacy. So choose your agents that will help support patients getting to goal and maintaining the goals. We also included language on recognizing the importance of weight in type 2 diabetes and long-term outcomes. And so in persons with type 2 diabetes where weight is part of the picture, the preferred pharmacotherapy should be a GLP-1 receptor agonist or a dual GIP-GLP-1 receptor agonist with greater weight loss efficacy. And we tiered the levels in terms of efficacy on weight loss, with your very high efficacy being semaglutide or tirzepatide, and then followed by high, intermediate, and neutral. So now that we've had all this progress with therapies, how are we doing? If we look at the different databases, we see that over time, from 2011 to 2021, our proportion of patients achieving A1C goals hasn't budged too much. Here we see A1C in adults with diabetes and an A1C of less than 8% that is essentially unchanged over the last 10 years. And so this has been a high priority for the American Diabetes Association because the ADA publishes its standards of care every year, but what good is it if we can't keep up? And so despite more drugs, despite more education, despite more technology, the average A1C hasn't changed. And in terms of complications risks, what we worry about is that the number of persons with type 2 diabetes with an A1C over 9% has actually increased over the last 20 years. The ADA has established its OTI movement, Overcoming Therapeutic Inertia, and I really want to recommend the resources on the American Diabetes Association website, including this 5-minute video, which is highlighted here. And that is, just some bullets on treatment intensification. We know that only 5% of persons with type 2 diabetes on Medicare use diabetes self-management and education services, for example. We know that reaching A1C targets soon after diagnosis predicts better long-term control. We know that persons with type 2 diabetes say they are willing to do more than their physicians believe they will do. So there are a lot of findings and a lot of areas that we need to work on. And we also know that less than 50% of persons with type 2 diabetes continue or persist on glucose-lowering medication after 1 year. Lots to work on. So let me highlight for you now the OTI initiative, the ADA Overcoming Therapeutic Inertia initiative. Again, lots of resources on the American Diabetes Association website, but I want to highlight the three main bubbles of focus. One is in research. Two is in collaborative barrier busting, realizing that we can't do it alone. It really does take a supportive network and alliance. And then third is education and awareness to promote clinician success. The website has a lot of great wisdom and tools that one can download and incorporate into their own practice. I'm going to highlight a few pearls that I think are particularly valuable in terms of understanding the impact of therapeutic inertia on persons with type 2 diabetes. One of the recommendations that I feel strongly about is to schedule diabetes-only visits so that you know what the focus of the visit is and it becomes a shared goal for the patient and the clinical team. And so we know that if we can focus on diabetes, we can really impact long-term outcomes in other health areas. Also asked office staff to remind patients to bring their glucose logs, list of medications, monitoring devices, aim to adjust therapy when the A1C is not at goal. Set that as part of the expectations. It's no fault, no guilt of anyone at all, patient or provider, but keep the eye on the prize of A1C. And consider making changes between A1C tests based on monitoring results. Another area is it's important to recognize when there are barriers. So to recognize therapeutic inertia, check for barriers. Is there diabetes distress? Is there depression? Is there low health literacy? Are there social determinants of health impacting advances in care? Another common technique that we use in practice is to schedule the follow-ups based on where you're at. So if the A1C is quite high, schedule a sooner follow-up, for example, 6 to 8 weeks. If the A1C is a little bit high, 7 to 8.9%, schedule it modestly sooner, every 2 to 3 months. Only when they're stable, then you can have the follow-up scheduled every 3 to 6 months, for example. And in terms of planning with patients, develop a diabetes care plan that includes a personal A1C target. Let everyone know what the goals are of care. Take into account the patient needs, the patient morbidities, concerns, and wishes, and review the target goals with the patient on a regular basis. Also, it is recommended that all patients should be referred for diabetes self-management education when diagnosed or if they've not received this before. I highlight here for you the American Diabetes Association campaign to overcome therapeutic inertia. They started with a call for applications for grant proposals and ideas a few years ago, and have really developed an elaborate website with toolkits based on the learnings, as well as lots of educational programs. So you can explore the toolkit, look at the insights, and listen to the webinars and podcasts highlighting the community of experts. Here's one publication that I want to highlight, showing some of the research areas that are in place to try to overcome therapeutic inertia. One is looking at care management and patient education-based approaches, including virtual patient coaching, self-management education, glucose telemonitoring as examples. There have also been physician-based programs throwing additional education towards the physician. So looking at education regarding guidelines, in-person training and support from specialists, and face-to-face feedback, as well as computerized or digital reminders. Two of the most promising that in terms of study data are nurse or CDCES-based approaches as well as pharmacist-based approaches. Now, in both instances, there's evidence-based guidance and protocols that the clinical team can use to support helping patients get to goal. And what I found interesting in this publication is that if you just utilize education alone without the intensification protocols, you're less likely to get effect as opposed to marrying the treatment titration protocols with education. What other models are there? So here's a publication that I appreciate from Mosenson and colleagues, where they said, you know what, for most patients will be at higher cardiovascular risk. For most patients, you can approach a simple algorithm, and that is looking at lifestyle modification, education for all. And for most patients, they'll benefit from foundational metformin and as well as disease-modifying therapies, or GLP-1 receptor agonists and the SGLT2 inhibitors, where there are outcome studies demonstrating their benefits in ASCVD, in heart failure, and in chronic kidney disease. And for patients who are in a catabolic state or have symptomatic hyperglycemia or an A1C is elevated above 9%, that's where you incorporate your quickly effective therapy of basal insulin. And another model that I want to highlight is done at Vanderbilt. So this is the Vanderbilt Collaborative Diabetes Management Model, recognizing that there are a lot of patients with diabetes and perhaps not as many specialists. So here's a tiered approach where all patients with diabetes in the panel are seen by the primary care provider. If the patient is meeting their goal, they continue to follow up. If there's evidence that assistance is needed or the patient is not meeting the goals, they're referred to a 12-week program focusing on diabetes self-management and education support, as well as medication optimization. And then for the complex patient, there's an open dialogue and referral to the specialist. So this would be the endocrinology referral. For example, in someone with refractory hyperglycemia, comorbid complications, severe hypoglycemia, severe insulin resistance, or refractory hyperlipidemia. And now let's switch to patient misconceptions and beliefs about treatment intensification. Why do patients resist therapeutic intensification? I think we can all think of anecdotes that come to mind from our own personal experiences. Here are some highlights from the publications listed below. A meta-analysis of 8 studies of medication beliefs among persons with type 2 diabetes found concerns about general worries about adverse effects, general worries that medications are overused, specific worry about the necessity of a medication, specific worries about a particular medication. Importantly, these concerns are listed as moderate, suggesting amenability to change through education. We also appreciate that therapeutic intensification may be resisted by persons with type 2 diabetes who weren't told that the progressive addition of therapies is expected, who view intensification as punishment for poor self-management, who feel that intensification represents worsening health, who are self-managing multiple chronic diseases, or who have difficulty affording their medications. So these are some helpful tactics for increasing patient comfort when intensifying type 2 diabetes treatment when needed. The top 5, and I really want you to think about your own patient examples because we've all had these conversations and dialogue. So many patients want to know how the medication will affect them more than how it works. So take the time to explain to help the patients know what adverse events might occur, how to take the medication, how it might reduce long-term risks, the benefits and risks of the different medications, make it a shared decision-making process, and how it might fit the needs and lifestyle. Also, what's been shown in this survey is that primary care physicians need to be more comfortable with the medication and have a supportive team to help them. We can't do it all alone. So really think about your team-based care, your shared care model, CDE or others that can support teaching, EHR alerts, time-saving strategies, and assessing time and range with CGM. Technology really may be able to change how we care for patients. So some helpful clinician strategies to initiate and persist on insulin and other injectable medications. There's things that we can do throughout. So at diagnosis, what do they believe about type 2 diabetes or about the medication? Explain the importance of glucose control and that treatment might evolve over time to include insulin. Prior to insulin initiation, gauge perceptions of insulin treatment. Explain benefits tailored to pre-existing perceptions. Reach agreement on the necessity and the why of insulin therapy. At initiation, reiterate insulin's benefits, demonstrate injection process, offer support that they are not alone in this process. And then even following initiation, ask about the experience with insulin, changes in energy, mood, weight, and ask how injections are fitting into the daily routine. Living with chronic disease can be difficult. And so this is where we need to make sure that we don't go down the vicious cycle of failure and that we can convert to a virtuous cycle of success. And what I like to think of it is trying to have an anchoring habit. So one positive change. The moment we have one positive change, it contributes to a cycle of additional positive changes. And we've seen this with GLP-1 receptor agonist-based therapy. So if we set realistic goals using the SMART goals, specific, measurable, achievable, realistic, and timely, when we make an effort and attempt some modification, some either in glucose monitoring, exercise, dietary changes, when that goal is met, guess what? It's empowering. The distress is reduced, meaningful benefits are noticed, and then there's greater adherence. And it's a positive feed-forward cycle. So let's take a look at some of the practice aid demonstrations to help clinicians apply the latest guidelines on weight management in persons with type 2 diabetes. This looks like a lot of detail, but I want to highlight a few things. One is that we are all in this together. It's an iterative cycle. And then two is that there are key principles that we do need to enforce, and there are conversation tips on how to do that. So we know that the nature of type 2 diabetes may change over time. So we need to set the stage for that. Treatment plans may change over time. Weight and health affect each other. These are all integrated with our full cardio, kidney, metabolic morbidities. And patients can't do it alone. We're in it together, and we should be encouraging patients to share difficulties. The healthcare team is here to help. So I highly encourage you to look at some of the conversation tips and keep these at your disposal. Also looking at SMART goals. So how do we make goals specific, measurable, achievable, relevant, and time-bound? It takes goal setting, conversation. Even something as what might seem simple as eat healthier, let's get granular. So including at least 2 servings of vegetables daily, keeping a food diary, starting with familiar vegetables, making sure that why they're doing it is relevant, and then evaluating in a time-bound manner as one example. Here's again the heat map, so you can have an understanding of how the different therapies, the incretin-based therapies, can match the A1C lowering and the weight loss goals for your individual patient. We've covered a lot of material, so I want to highlight here the key takeaways on intensifying therapy in persons with type 2 diabetes. It is important to recognize when glycemic and weight goals are not being met, and not to wait more than 3 to 6 months before intensifying or adjusting therapy. It is important to provide anticipatory guidance to patients about the potential need to adjust therapies over time. We're also in a really privileged era that we know that multiple health goals can be addressed by medications, including the GLP-1 receptor agonists, the dual GIP-GLP-1 receptor agonists, and SGLT2 inhibitors, which have demonstrated disease-modifying capabilities. Many strategies have been evaluated for overcoming therapeutic inertia. Find ones that have been tested in clinical settings like yours and give them a try. And finally, nothing succeeds like success. Help patients set SMART goals and initiate a virtuous cycle of diabetes management. That concludes my presentation for today. Thank you very much for joining me.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/NRC860.